Hello, and welcome to the Society of Hospital Medicine's Education Consult Series. My name is Dan McFarlane from The Ohio State University, and today I have with me Dr. Lora Sowunmi of the Cleveland Clinic and Dr. Christiana Renner of the University of Texas Southwestern. Welcome.
Thank you, Dan. It is so exciting to join you to talk about conflict management in the hospital. We're going to look at factors that lead to conflicts between staff members, explore their consequences, and then develop a plan for these situations and coming to a meaningful resolution.
Great. Well, I'm really glad that we were able to do this. I've had just a lot of frustrating interactions lately with some of my coworkers, and I was hoping that maybe you guys could help me. Dr. Sowunmi, I just feel like the ER is really not helping me, and I was hoping that maybe you could help me address it.
Oh no, I'm so sorry to hear that. Please tell me what's going on with the ER today.
Well, the latest interaction was the ER called to admit a 52-year-old patient with nausea, vomiting, and abdominal pain. Patient has a history of chronic abdominal pain with multiple flares and a history of kidney stones. They did get a CT abdomen, which showed no acute process in the belly, but they did show an acute subsegmental PE. The ER wanted to admit for the PE, but the patient was stable and on room air and had no pleuritic chest pain or shortness of breath. So I asked the ER to do a DVT scan of the legs to look for a proximal clot and discharge on a DOAC. He had normal renal function and all of his symptoms, including his nausea and vomiting, had resolved. But the ER said that in the guidelines, they don't recommend discharging patients with PEs on DOACs, and he was complaining to me about medical legal issues. And I just have had similar admissions all day, and I couldn't take it. So I just was like, fine, I'll just come down there and discharge him myself.
Wow, that sounds really rough. I apologize again and know how frustrating interpersonal conflict can be.
Yeah, I just feel like I need to reset my approach because these things happen. And I just wanted to see if you had any tips.
Yeah, I've actually done some research on this topic. So here's what I found, and I'll start with a bit of background. So some conflict with the ER during patient handoff is common and stems from differing perspectives, priorities, and contexts on patient care. The ER physician's goal is rapid triaging, diagnosis, management, and disposition of a large number of patients with varying acuity of care. The hospitalist approach is different. We are concerned about bed management and staffing resources and have a more detailed diagnosis and management approach. The workflow demands and differing perspectives on disposition can cause some friction. As seen in this graph from this 2021 study, there are various types of conflicts in this regard. Whether a patient requires admission at all, whether a patient should go to the ICU rather than the IM service, and whether additional testing is necessary before transfer to the floor. To review the first point, which I think is more relevant to your scenario, there is task conflict in this regard in that the IM perspective is that short admissions require substantial effort for limited medical benefit. The EM perspective is that there are other indications for admissions beyond medical indications. Regarding process conflict, the IM perspective is that EM physicians should regularly revisit admission decisions. The EM perspective is that EM physicians do not have the bandwidth to revisit admission decisions. Regarding relationship conflict, IM physicians view limited influence on admission decisions as frustrating, and rightfully so. The EM perspective is that IM physicians are unaware of EM physicians' efforts to avoid admission.
This makes sense. I never thought about looking at their perspective.
Yeah. And beyond this, there are other consequences of this conflict. Interdepartmental conflicts are difficult to deal with, but can also affect patient care. For the ER physician and IM physician groups, conflicts during patient handoff are associated with a higher risk of medical error and adverse events and can harm physicians, leading to burnout.
Well, how do you handle the conflict then? I mean, this seems really important to look at their perspective, but or do you have any tips for handling the conflict?
Yes, I do. So there's lots of tools that can be used to approach conflict, and I'll go over a few of them. Familiarity and trust can help the quality of your communication and help mitigate interdepartmental conflict. For addressing conflict in general, you want to control your emotional response, understand the situation from both sides, be flexible and vulnerable in your discussions, allow both parties to speak freely without using negative personal statements or insults, compromise and highlight areas of progress, and set goals for addressing unresolved differences and continuing issues.
Wow, this is very helpful.
Yeah, you're absolutely right. I also have some more tools to discuss. So this is some tips from the Journal of Hospital Medicine that was published in 2023, and they provide 6 steps to conflict resolution in healthcare settings. So check your vitals, understand the issue, be vulnerable, create alignment, define the new path forward, and have an exit strategy. For your specific scenario of the ED and IM conflict, you want to understand the work demands of both sides. Try to ease the work demands of either department, such as improving staffing. Consider additional conflict negotiation and communication training. Plan for joint departmental training, meetings, social events, and/or retreats to emphasize shared values. Along those lines, try to standardize care as much as possible with care paths and order sets. Approach discussions on patient handoff with a renewed perspective, seeing it as an opportunity to problem solve from a multidisciplinary perspective. How does that sound?
That sounds great. It sounds like I have a lot of opportunities to improve handoff and patient care, and really that's what I should be focusing on at the end of the day. As long as I'm a hospitalist, I'm going to have to deal with this aspect of my job, and this will really help make it better.
Yes, and I'm here to help if you want to tackle any of these departmental suggestions I raised. I'm always up for QI projects.
Excellent. Thank you, Dr. Sowunmi. Dr. Renner, I really wanted to discuss a different interaction that I had on behalf of my intern. Recently, I had an intern put in orders for a patient with hepatic encephalopathy who was quite ill, but the nurse refused to give the medications because she felt that the patient's blood pressure was too low. My intern got really upset because she felt patient care was being compromised, and my intern did try to discuss it with the nurse, but she felt the nurse was being very dismissive. She really didn't want to write a patient safety report because of fears of retaliation. She does work with this nurse fairly frequently, but she's also concerned that this might happen again. Are there any ideas that you might have how I can help her address this?
Wow, this situation sounds so familiar, and I might even be having a flashback to residency at this point. I feel like this is a pretty common situation in many hospitals in many different situations. And I really love this graphic on interpersonal conflict from Colonel et al. And this talks about this kind of the silos within the hospital. Internal medicine kind of forms our own silo. And then the other outgroups would be other specialties. So think of the conflicts we can have with neurosurgery or general surgery or neurology. And then the other set of outgroups is other different interprofessional groups. So think of nursing or hospital management, PT, OT, all those things. And it kind of becomes this us versus them mentality that we see across society in general in other forms and fashions. Added to this, there's a power differential. The nurse might perceive a power differential because the trainee is a physician, and so she feels like she can't adequately voice her concerns or be heard because she has less power. Well, the trainee might feel because they're a trainee that the nurse actually has more power. And so basically, they both are feeling like they're in this out group and they're both feeling like they're not heard. In addition, as Dr. Sowunmi brought up, there's a lot of different priorities. So nursing is often preoccupied with protocols and metrics that are often set by administration. And so that drive to meet the metric really disproportionately falls on them. And they often feel like they might get in trouble if something goes wrong. while the trainee might feel like they're under threat of peer review. So there's a lot of tension here, and it can create that burnout and conflict that Dr. Sowunmi was talking about. So similar to what Dr. Sowunmi said, this is actually the same principles. In all these situations, I would think about checking my vitals, going back to try to understand what the underlying issue is, not the surface issue that we're talking about. Being vulnerable about what we both want, and then creating alignment to emphasize what we both are trying to accomplish for the patient. Based on that, we can then define a new path forward and create an exit strategy to resolve the situation.
Well, it really sounds like these are a lot of the same principles for all of these different interactions. Do you have any specifics, though, for nurses or really patients that are different levels on the hierarchy? I know that with Dr. Sowunmi, I was talking about sort of a peer interaction.
Yeah, no, that's a great point. So I think that here the thing that I would do is really try to understand what the nurse is concerned about. So the nurse might be concerned because she's got a lot of other patients who are ill that night. Her perspective is that this patient is confused and altered, and that they can't that they won't be able to get to the toilet, and her whole night's going to be taken up with just trying to help this one patient. So I think asking what is your concern about this, as long as it's not an emergency, and then giving it your full attention. I know my default is kind of to try to do 5 things at one time, and I'm not really listening sometimes. And then to actually, instead of saying, I want you to do this, approach it with humility, saying, hey, this is why we're doing this. This is what our goal is. Is there some other suggestion you have? And then you can set parameters with that nurse. Say, hey, I'm not wanting the patient to have diarrhea. I'm wanting like 4 bowel movements in the next 24 hours. And, if things are happening more rapidly than that, then we can slow things down. And then coming back and saying, I'm going to check in with you in 2 or 3 hours. And then actually doing that to create that trust between you and that nurse down the road. It can also help head off pitfalls. This is actually a tool. The nurse tool is not specifically for nursing, but it's a tool used by palliative care with families and patients. And so I think I really like this in situations like this as well. So you name the problem, you try to understand what's going on, you show respect and support, and then you explore other options. So in this situation, what I might say is, look, I understand that this situation is very frustrating and you have a lot going on tonight. You have these other sick patients and you're worried that you won't be able to provide the best care. I know that's what you want to do. So let's just at least give the first dose of lactulose. I'm going to come back by in a few hours. I'm setting my alarm on my phone right now to check in and see how things are doing. And then we can come up with a new plan then, if things aren't working, to figure out how we can help this patient do well together. How does that sound?
That sounds fantastic. I really appreciate all of the help. And I think that I've got a lot of tools that I can use to help navigate these things in the future.
Yeah, I also like this mnemonic, even when I'm supporting a trainee or a student who's struggling with communication about something. I think it's a very useful tool to have in my toolkit. So, in the end, we've covered a lot of things today.
Yeah, so to summarize, I think my key takeaway when dealing with conflict is to just slow down, take a deep breath, and check your own emotional response. I think that goes a long way with neutralizing the situation.
I think for me, the biggest thing I'm going to take away is really looking for opportunities for collaborative solutions and working together to kind of figure out different perspectives and come together in a compromise.
And then what really resonated with me is that not just to deal with the immediate problem, but to think about more broadly about it and later come back to revisit the underlying issues, whether in the case of the nurse with all the sick patients, maybe improve staffing at a later time when heads are cooler. Thank you so much for this opportunity to talk about conflict today with hospital medicine.
I
Thank
appreciate it.
you.
Thank you,
Thank you,
everybody.
everyone.